the most important thing about a brace is to get one that fits and that does what you need it to do, because there's so many different braces. There's braces for stenosis, there's braces for fractures, there's braces for lifting, and there's braces for support for the pelvis, not the back. And so you have to be bracing the right parts of the spine. So it's important, if you're going to invest in a brace, you can get one from a physician, and Medicare and insurance generally pay for them. You don't have to pay cash, and you shouldn't pay cash anyway, because you could easily buy the wrong one, because there's so many out there, and they're for different reasons. The different brace could be appropriate. A corset is the soft brace that wraps around and usually Velcro, and that's the one that's usually at the store. And you can often find a better brace than that if a brace is right for you. But we don't do a lot of bracing except for fractures, vertebral compression fractures. Modalities in the gym that we have: hot, cold, massage, ultrasound, e-stim, traction. Those things can help pain. They're not going to cure you, but they do help, and they get blood. Certain these things get blood to the tissue and do certain things to the physiology to make you feel better. Manipulation, you have to be careful. That's one of the reasons we need x-rays, to make sure you don't have any instability in your spine. But manipulation, whether it's from a therapist or a chiropractor, why does it work? We don't know what it does, but sometimes it feels good, so it's okay. Injections, we perform injections to different parts of the body. Injections can help. Generally, it's a steroid mixture with an anesthetic. Steroids help calm down sensitive or inflamed tissues, so steroid injections work for certain situations, especially when there's inflammatory problem. If you get the steroid in the right spot, you're going to knock out the inflammation, and patient's going to think you're a genius. But a lot of problem is degenerative, not inflammatory. And so you have some patients say, well, or patients come in and say, I had steroid shot, it didn't work. So it's not always clear if a steroid shot would work. We can do other things that don't involve steroids for degenerative process, like burning the nerves, ablation procedures to some of the nerves in the back that can help. For spinal stenosis pain, for leg pain and herniated disc, steroid shots work very well. It's often can buy patients time to avoid a surgery while their body gets better. Sometimes you get patients come and say, I had a steroid shot 3 years ago, and it worked for 3 years, I need another. And you say, well, you know, it worked for like 3 days. Your body did the rest. The steroid's going to just work for a few days, okay? You're trying to calm down that tissue with a steroid shot to stop that cycle of inflammation, and that's how the steroid works. It's not like it sits there and works for 3 years. So we say, I can't promise that's going to happen again. But certainly there's a lot of patients that benefit from injections. We have to figure out where to put it and why we're going to put it there. If we can figure that out, it might help. For arthritis, degeneration, it doesn't always work. Just like knee osteoarthritis, if you give a steroid shot, it could help, but it doesn't take away the problem. That's degeneration of the cushion. It stops the inflammation. So if you have pain because of inflammation from the bone just grinding on itself, a steroid shot will help your knee arthritis. If you have pain because the bone is grinding on the bone, it doesn't change that. The bone's still going to grind no matter how much steroid you put in there. So that's the problem. If you do too many steroid injections, you're going to make a healthy person look unhealthy. They'll start to gain weight, and you can cause weakness in the bone. So you have to be careful how many shots that you have, or if you go to one doctor for shots here and another doctor for shots there, and they don't know everyone's doing shots, you can cause problems. So steroid is good, but too much steroid is not necessarily a good idea. So in a limited role, these can help. The nerve ablation procedures provide a more long-term pain management for arthritic type problems in the spine when those work. Injections can be helpful to predict the response to surgery, because then you know if you're able to calm down that sensitive tissue, the surgeon maybe could cut that sensitive tissue out of you and make you better for longer, okay? But there is a good response that we can reduce the number of surgeries we do with shots, and that we can help to predict who's going to do well with the surgery from the shot. This is a patient that you would assume probably has back pain based on the MRI. You see a lot of healthy discs. The white is water. That's a big, tall, healthy disc. And then you see one that doesn't look so hot. He's flat and he's turning darker and darker, but there's nothing back here. When the disc herniates, it pops out here. And like I said, the body will heal itself. Usually those disc herniations, if you give it enough time, it could be 6 weeks, it could be 6 months, it could be 6 years, your body will often reabsorb that disc herniation. When people are screaming in the office or ER, they are not going to imagine that for 6 years, so sometimes those people end up having surgery. But if you were able to give it time, your body would probably get rid of it. When it becomes a problem, and you keep going to the doctor saying, what should I do, what should I do, my back is killing me, you could end up say, well, we can just take this disc out of the equation, and that's by fusing it together. And that can be appropriate sometime, but it's certainly no guarantee that stacking this disc together to this one with a screw and pin set called a fusion is going to cure the back pain. You think the disc is the problem, and so you remove the whole disc, and you put in even a fake disc, and you fuse it. You can do it from the front, the back, the side, or all three, and the patient could have the same pain afterwards. And you say, but the x-ray looks good, you're cured. Go see the pain doc. So fusion for just low back pain alone has a low degree of success. It's certainly no promise. For leg pain, the surgical treatments have much higher success rate, 85, 95% success rate for these problems. But you have to think, the surgeon said I have 90% success rate. He's talking about your leg, not your low back pain. So if you're not going to be happy to have a surgery to get rid of your leg pain, if your back pain's still going to be there, there's not much point to have the surgery. So when they talk about their success, they're usually talking about their leg pain success rate, because no surgeon should promise the back pain is going to be cured by the surgery. It can get better. If the pain is from the pressure on the nerve and you take the pressure off the nerve, then you're going to feel better, and it could help your back pain too, but there's no promise of that, and no surgeon can promise you that. Not that we don't do it all the time, we don't see it all the time, it's unpredictable. Because what the surgery doesn't do is it doesn't cure you. It removes the disc that's coming out, okay? Or it takes the pressure off the nerve, but it doesn't reverse the clock. It doesn't make things the way they were last year. It just takes away the urgent issue, like the pinched nerve or the tissue that's sitting on the nerve, whether it's arthritis or disc herniation. But it's not a curative type of a surgery. We do fusions. When we do that, like you saw those screws, if there's trauma, instability, if you did a disc herniation, if you did a discectomy and it came back out 2 weeks later, and you did another discectomy and it came back out 2 weeks later, you go back to the surgeon, he says, fool me once, shame on you. Fool me twice, shame on me, right? So third time you could get fusion for recurrent disc herniations. If there's going to be instability, if the disc came out too much, or if the joints in the back were unstable from arthritis, sometimes you have to put these hardware pieces in. But so these are indicated. They are proven to be successful in certain conditions, but certainly you have to be careful who you're putting the hardware type in. If you put a hardware like this in a 30-year-old, they're going to need surgery again on their back later in life. If you put a hardware in a 70-year-old, there's a good chance that you're not going to have to go back in and do another surgery. So in the right patient, it's the right surgery. But for younger patients, you have to be careful when you're doing that to the back. Like I said, we have surgeons and non-surgical specialists in our office. We know how to refer for a surgery. We always have talk about patient when you need surgery. Indication, spinal instability, progression of a neurologic deficit, intractable pain, bowel and bladder problems from your spine. Otherwise, we try to get you through it without a surgery. If it hasn't gotten better over a couple of months, or if it's getting worse, it's unlikely to just spontaneously get better at that point. You might want to talk to the surgeon. If you are in the pain and clinic, you had back and leg pain, we give you a shot. They say, this is great, and then you came back 2 months later, says it's back, and you do it again. They came back 1 month later. You just say, well, you could try one more time, okay, but at some point, it looks like it's not going to be a good long-term thing, but you have good chance if the shots help, the surgery would be helpful. When surgery fails, or if the doctor says surgery is not a good idea, or if the shots didn't work, we have other options. This is a spinal cord stimulation device.